Hello, everyone. Welcome to our fourth webinar for the International Peptide Society. Again, my name is Emily Fox. I am the membership coordinator for IPS, and I will be moderating the webinar for this evening. We will be talking about Thymosin Beta 4, and just a quick recap on the International Peptide Society, some benefits that you get by becoming a member. You get access to full journal articles, not just the abstracts. You also gain access to learning opportunities, including conference weekends, webinars, and annual IPS Congress. You also get exclusive back-end access to the website for the doctor-only forum. So this is a place for doctors to share their clinical outcomes, data pages, and protocols with each other. And before we get started, I just want to encourage you all to join and be involved on the forum. And if there's questions that we don't get to tonight, to definitely take advantage of that forum as well, because we check that on a daily basis. So again, if we don't get to any certain questions answered here tonight, please do go visit the page. With that being said, we're just waiting for a few more people to join on, and then I will hand it over to Dr. Seeds tonight to talk about Thymosin Beta 4.
So I want to thank everybody tonight for showing up again, and people who come on later or go on to the website to follow our webinar presentations, where we're trying to cover most of the basic peptides that you will encounter in your practice, and I think will be significant in moving forward with improving patient outcomes and patient care. And this Thymosin Beta 4 is really one of my favorite peptides and workhorse of a peptide that covers the spectrum, I think, in from cellular repair to autoimmune disease, and it's just an amazing peptide, and I'm excited to talk about it tonight. So let's get going here. Thymosin Beta 4 is one of the isoforms. They're really, there's the thymosins are the alphas, the betas, and the gammas, and we're talking about thymosin betas, and the beta 4 is one of three isoforms. There's the beta 4, the beta 10, and the beta 15. But the beta 4 is one that we are most familiar with and most familiar with in use of clinical trials, and the one we're going to discuss tonight. It's originally isolated from the calf thymus. It's ubiquitous, occurs in almost all cells. And what I think is really interesting is what we found in the brain, this TB4, and how it's upregulated in the microglial cell for immune problems in the brain and actually in neural protection and so forth. And that's a fascinating area that I think you're going to see a lot more research on Thymosin Beta 4. But let me stay on track and quit digressing. 43 amino acids. We'll see higher levels in the platelets and white cells. It does cross the blood-brain barrier. Thymosin Beta 4, it upregulates actin. That's really one of the crucial activations of Thymosin Beta 4 intracellular within the cell. It's G-actin sequestering peptide. It forms a ternary complex with actin and propylin. It increases cells involved in healing, basically it can modulate stem cells and modulate stem cells recruitment and differentiation into mature cells to basically heal skin problems, myocardial problems, brain, eye issues. I mean, things that we'll go through here in a minute. But it's really an amazing peptide. It improves cell migration to the site of the injury. It promotes the matrix or proteinase expression during wound healing, which these enzymes are very important, in the breakdown of matrix and of the cell to promote healing, and that's a very important point. Anti-inflammatory, it promotes angiogenesis, it increases collagen deposition, and at the same time, it's cytoprotective, and it prevents or stops apoptosis of the cell. That's pretty amazing. Thymosin beta 4, it helps to decrease scar tissue. It reduces the level of myofibroblasts, which is very important in wound healing. And more specific, if you're looking to use it specifically for ligamentous or tendon injuries or muscle injuries, that's our primary detriment to healing is scar tissue, and we're trying to avoid scar formation as we are looking to heal these type of injuries. And specifically, the scar tissue formation, decreasing that is one of many, I think, fantastic attributes of thymosin beta 4. It's also used in immunity. It has antimicrobial properties. It improves T cell function, and it can be used and stacked with thymosin alpha 1, as we discussed before, the amazing immune properties of thymosin alpha 1. Well, TB4 can be used in conjunction with thymosin alpha 1 to assist in upregulating or synergizing with the thymosin alpha 1 for certain immune protocols. And again, as we said, it's a neuroprotective. Thymosin beta 4 has significant neurogenerative, in fact, in budding of neurons and in promoting stem cell activation actually in the brain. TB4 can be very significant, and also on the other side, it can be important in protecting from ischemic injury of the brain and also apoptosis of the cells in the brain. This is just a nice schematic of kind of looking at all of the areas that TB4 is related to as far as wound healing, promoting wound healing, and anti-inflammatory effects, and then where things kind of meet in the middle with, as you can see, with the adhesions, the migration of the cells, the actin binding, the antimicrobial effects, the anti-apoptotic effects, the MMPs that we talked about, transforming growth factor beta. I mean, there's some very impressive properties of thymosin beta 4 that are related both to healing and anti-inflammatory effects. And what's interesting is how it can modulate these without going overboard, just like we'll talk about with BPC 157 in the future and some other peptides. It's amazing how these peptides have the ability to keep the healing process kind of in a homeostatic pattern without causing the system to go out of sync and cause maybe too much inflammation or not enough inflammation or just enough angiogenesis. And that process of maintaining that homeostasis during these healing processes, I think is substantial. And I believe I'm sure we'll get a question here with the stem cells, but I think it's just an amazing adjunct to use if you are in the practice where you do use stem cells. The TB4 can be an amazing adjunct for helping in mitigating the environment for those stem cells. Remember, you're removing those stem cells and from one area to another, which is really going to kind of change the environment and causes a lot of problems that you don't quite see documented in the literature about. Changing the environment actually changes the activity of the stem cell, and what you really want is that stem cell kind of in a hardened, adjusted state. And so the TB4 can be very helpful in kind of getting that stem cell back on track and helping it go through its maturation process and differentiation, and also help with its self-renewal process, which is just as important as the regenerative process of the stem cell. And the nice thing is that can be used, the TB4 can be used in site, meaning, if you're going to use stem cells for a specific area of the body, the TB4 will not be something that will change the, you've already injected the stem cells. You're not changing the structure of the stem cells. You're adding the TB4 that is going to do its job after the stem cells are in situ. So you're not doing anything to change the structure of the stem cells, so to speak, as we need to be aware of with the current rules and regulations in using stem cells. But I thought that was just something important to mention. As you can see, I'm very enthusiastic about this peptide. So soft tissue repair, tendon, ligament, muscle. I mean, in athletics, this is an invaluable peptide to repair any of these injuries, and to not only to repair them, but to repair them in as an anatomic position as you can, and that's really important to as far as function with reducing scar tissue and reducing that myofibroblast proliferation. Scar tissue is the enemy of good, and scar tissue, anything we can do to keep that limited, and especially in any athlete, you don't want to tolerate any of that process in ligament, tendon, or muscle. And the other aspect is the fact that TB4 is not only is it effective in reducing scar tissue, improving the factors necessary for recruitment for healing, but also mitigating satellite cell activation and migration to the site to help you repair the specific tissue you're looking for. But even as important is the acceleration of this healing process that you get. And I think that in conjunction when, as you guys learn more with us with the value of these peptides, in being able to stack these with some other peptides of similar anti-inflammatory properties, cellular protective and reparative properties, you start to learn that, wow, when you use some of these things, you've got a pretty powerful cocktail of peptides that can really assist you in getting tissue back to its optimum state from any significant injury area. So pressure, venous stasis ulcers, TB4 can be very effective conditions with immune response modulation. I mean, it's an amazing peptide, right? It goes from cellular repair to inflammatory states to working with immune cells in upregulating T cell function. I mean, that's incredible. Brain issues, if autoimmunity suspected, as I discussed, the issues of where they're looking at TB4 and its the aspect of TB4 in the brain and within the microglial cells, and they're also looking at TB15 and TB10. I mean, it's interesting to understand, when the when in development stages of the early of the nervous system in the brain, the Thymosin Beta 4s and 10s and 15s are crucial to the development of the neurological system in the brain. So with that knowledge, you can realize that the importance of these thymosin peptides, where we're looking now at in many aspects of ischemia, stroke, autoimmune diseases in the brain, and using these with other conjunctive therapies to assist in trying to improve inflammatory states of the brain and reduce that significant post-inflammatory state sometimes where you get the cytokine storms that can wreak havoc specifically in the brain. So just a great and interesting peptide that you're going to see a tremendous amount of literature in the future on these thymosins and their applications. So spinal cord injuries, as we talked about, concussions, and in conjunction using BPC with the use of TB4 and BPC 157 for post-concussive syndromes. There's a lot of great energy looking at these issues right now. Dry eye disorders, phase 2 clinical trials with RegenRx, corneal issues, phase 3 trials for the epidermal myelitis bullosa, lung inflammation, fibrosis, and even people, there have been some studies that have been going on independently, and people looking at the use of using thymosin in conjunction with stem cells and PRP for the use of for the use of hair growth, and that has been something that has actually been, I want to say, I think it was one of our docs has done a couple presentations on actually the use of thymosin beta 4 and the use of stem cells in hair regrowth. So some interesting topics that are going on with that. The cardioprotective aspects of thymosin beta 4, improving cardiac wound repair, antifibrotic, which I think is very important in the proangiogenic, reducing the infarct volume and preserving cardiac function in preclinical models of cardiac ischemia used for hypoxic heart and heart failure. I mean, these are some critical areas that we're starting to really pay attention to, how we can utilize TB4 emergently, using it in a cardioprotective mode. I mean, think of TB4 and the things we know about the GHRPs, GHRP2 and 6, and the ipamorelin and the hexarelin. Those cardioprotective aspects of those peptides in combination with TB4, and then you talk about BPC. I mean, there's these models of additive effects of I think how we're going to start looking at ways of cytoprotection of the heart, cardioprotective aspects of where, people at higher risk or of ischemia, things that we can do to, if let's say there is an infarct, the volume can be reduced, we can preserve the function of the heart, and reduce that ischemic area that's affected. And I just think that the literature coming out from the cardioprotective aspect is just amazing. The non-alcoholic fatty liver disease inhibits oxidative stress, decrease pro-inflammatory factors, decrease hepatic fibrosis. I mean, there have been some great studies just showing like any end organ disease where they've actually looked at survival rates of patients with disorders of where they've shown the organ is at a higher level of failure, and they've measured the amount of TB4 produced by the cells, and the patients with the higher amount of endogenous TB4 produced by those cells of the organ are the ones that survive. The lower ones don't survive. And they've actually done that in looking at the liver specifically. So it tells you the significance of the cytoprotective role of thymosin beta 4. It decreases endotoxemia and sepsis. So you have another, you've got another way of evaluating aspects of endotoxemia and septicemia that we've talked about with the thymosin alpha 1. So you've got a way to really adjunctively add some of these aspects in stopping that cytokine storm of sepsis, but actually, synergizing with the things like with the other peptides like thymosin alpha 1 and any other aspects that you're using in the treatment of endotoxemia and sepsis. So we've shown that it reduces the polymerization of G-actin into F-actin, and it improves mortality rate. I think what's interesting in showing the use of some of these, a lot of these clinical studies is they've used high doses of thymosin beta 4 intravenously in some of these clinical studies for looking at end-organ disease, and they've run these thymosins for as long as 3 months at high doses IV, with no reports of cancerous or malignant formation, which is one of the aspects that we do think more about with thymosin beta 4 because of its significant proliferative and angiogenic factors. But we've got literature that shows, at least for 3 months, with high dosing, like 50-fold high dosing of thymosin beta 4 with no significance in cancerous formation. So I think there's just so much that we could cover with this, and I just wanted to kind of give you a little taste of the process of thymosin beta 4. Again, in our courses coming up, we'll be talking in depth about this and definite protocols and uses, and I think you'll get to be very comfortable, and this will be one of your mainstay peptides in treatment options you have for cytoprotectives, reparative, regenerative, and as an anti-aging peptide. I mean, I think it definitely fits in all those categories. General dosing with thymosin beta 4, it can range from 300 micrograms sub-Q, this is injected sub-Q, up to 1 milligram a day. Typically, I wouldn't go over 7 to 8 milligrams a week in your higher range, and that all really depends on the presentation and what you're trying to do. You know, if you're using it more cytoprotective and you're trying to protect an athlete or protect, just be in a mode of better recovery and so forth, you can go with the lower dosing of the 300 micrograms. And you know, if you're dealing with injury, acute injury, you can go as high as 1 milligram a day, and even up to just a little bit more maybe, but I'd say a total of 7 to 8 milligrams in a week, where that significant change in using the thymosin can very, very much assist in the more significant injuries, and again, if you're using it with stem cells or you're stacking with some other peptides, it kind of can vary. Based on the studies, that's why I don't recommend using it more than 3 months. We know up to 3 months with high dosing, we haven't seen any issues, so I kind of stick to the 3 months and then cycle off for a month if you need to use it again. Typically, though, I mean, I don't typically use the thymosin. I don't need to use it that long for an injury of what you're, unless you're using it in a protective mode after you've healed somebody from a tendon, ligamentous, or muscle injury. But I would tell you that probably the most consistent length of time of using a thymosin beta 4 peptide for injury is probably about 4 weeks. I've been in scenarios where I've used it for 2 weeks. I've been in scenarios with 4 weeks, 6 weeks, 8 weeks. Again, it's all depending on what you're trying to do. And again, we'll go into a lot more detail with this peptide of exactly those scenarios and how it can be used. And as I said before, used in conjunction with thymosin alpha-1, BPC 157 concurrently. And again, the individual requirements just vary based on clinical presentation. So that was a very brief summary of an amazing peptide that has been utilized all over the world by covering, I think, a lot of silos in the medical practice, you know, from regenerative to cytoprotective to reparative processes that we all work with. So hopefully that was a good summary. And I got to actually tell you about, had a friend, just before we jump into these questions, I had a friend who was traveling out of the country, was one of those traveling from afar, you know, 30-hour flight time, traveling across continents, who fell asleep and actually incurred one of those Saturday night palsies where he lost complete radial nerve function from just above the elbow down, right where you would get compressed. He was just kind of fell asleep in a chair and compressed his radial nerve and got a complete palsy. And I want to tell you something. We did everything. Now this is where, you know, a lot of these things can come together, but TB4 was a real important peptide we utilized in getting back his nerve function, which can typically, when you see those palsies, in practice, those things typically take 3 to 4 months, some up to 6 months to come back. Most of them do completely come back, but they can take that long. We had his nerve back in probably 4 to 6 weeks, 100%. I think that is compelling, amazing, and just tells you the power of, if you know how to utilize these peptides in the proper place and time, there are incredible things you can do with it, with these peptides. So I won't digress anymore. I'm sure there are probably some questions and things that maybe people have, and I'll turn it back to Kelly. Thank you.
Thanks, Dr. Seeds. Let's see here. So we're going to end the webinar with just a few questions here. And again, if there's any questions that we do not get to tonight, please visit the forum. That's a great place to post any questions that you might have. And Dr. Seeds himself and some other doctors can obviously pitch in and reply back with their answers as well. So our first question for tonight is, let's see here. So I have a lot of high-level athletes in my practice. Is this banned by the WADA?
It is banned by WADA. Yes, it is. You gotta be very careful in using it. Depending on the profession of the athlete, if you contact, depending on what sport, if you have somebody that's injured and you present a letter focused on the injury and the purpose and the use, sometimes that you can have that accepted if you have a treatment protocol. I mean, actually, that's something you can work through the IPS with if we can assist you with that. We'd be happy to do that for the athlete. But I will tell you that TB4 is a WADA-controlled peptide, and it's a shame, like a lot of these peptides, which are just purely for amazing reparative function and restoration of recovery, and they're not valid at this point in letting athletes partake in those peptides. So you have to be very careful with that peptide, and that peptide does stick around in the urine for urine testing. So yeah, it stays in the urine a little bit longer and can be detected, and they do look for it.
Awesome. Thank you for that reply, Dr. Seeds. Let's see here. Our second question. Could TB4 or BPC 157 be used for TBI that is old, so something that has occurred over a year ago?
Yeah, I think there's an interesting paper that, and I should put that up on the forum, that was just that came out just specifically about the BPC 157 for the potential still improvement in neural inflammation and issues that occur post-traumatically from ischemia and stroke. And I can tell you, so has there been anything specifically, protocols or studies that have followed what you're asking? The answer is no. But I will tell you anecdotally that, yeah, I've had other physicians that have had great success with improving. They're not getting 70% improvement or 50% improvement, but they're getting some improvement, 25% improvement. I mean, definite areas of improvement, potentially like with speech, gag reflexes. Then if you specifically on the type of stroke and ischemia, when you combine those peptides, so I'm really big on combining those two, on the BPC and the TB4. If you can utilize those together, and if you have more issues with muscular loss, then I've seen some amazing things with the use of of when you then try to, once you start to try to heal the neuroinflammatory changes of the brain, you can actually turn some muscles back on and get them working with people that have been out for a year or two, have been in nursing homes. And I can tell you, I know this is possible. Even without peptides, I've seen some things where we've done some, where we've reestablished action potentials across muscles to kind of get that pathway started again, where the brain's probably already done its healing. And that's with using a complex device to create a physiologic signal, action potential for true muscle function. But I have some very big interest actually in combining all of those aspects, specifically for stroke victims. So that's a great question. There's a lot of dialogue that as we get more of our neurologists involved in IPS, I think we're going to see a lot more discussion with these peptides.
All right, great. Let's see here. We've got about two more questions we'd like to ask this evening. Our third one is, what are the risks for my patients who have had a history with cancer?
Yeah, so that's a good question, and my response to that is, I guess depending on the tumor, I wouldn't recommend the use of the TB4 with anybody with a history of cancer. And again, I think and that's a general blanket statement that just because of the significant migration and angiogenic factors that are specific to TB4, I think you got to be very careful with it. Now, again, it comes down to each individual treatment plan and protocol. Can you use it in short periods of time? Maybe that's a possibility, but I think it's individually. But as a general statement, I'd say anybody with a history of cancer, that would not be an advisable use of TB4.
All right. Thanks, Dr. Seeds. We're going to close our webinar with our last question this evening. We have a doctor asking about the dosage and frequency and protocols for different conditions, such as in the autoimmune disease, like Sjogren's syndrome.
So yeah, so autoimmune diseases, I think you're in a good. So for increased, for looking at trying to look at where the body is when it's gotten to that place where you have that autoimmune process where the body's fighting itself, I think that's where we start looking at using these higher doses of thymosins. And specifically what you're talking about, I think using a milligram a day for at least up to, as I stated before, up to 3 months is a reasonable protocol to see how the patient can respond specifically to that. And then I would stop it, as I said before, for like 4 to 6 weeks, and then I would again put them back on it, and I would go through that cycle for up to a year. And I would be, I'm more than happy to correspond with you on the site with following you with patients like this. I think there's just a lot that we're looking at different protocols and also with autoimmune problems in combinations with such as the thymosin alpha 1 with the thymosin beta 4. And also we're looking at the melanocortin receptors, specifically melanocortin 4. So the possibility of looking at right now a way to manipulate that is with one of the melanotan 2 actually melanocortins that where we can kind of use all these in conjunction in treating autoimmune problems like this and like Lyme's disease, because we're trying to do everything we can to get the body back into some management and control. So that just gives you an idea on a protocol like that. As again, I said, I think 1 gram, and you know, you can do the test dosing of that can be, you could start off with 500 micrograms for the first week every day, and then go up to 1 milligram a day for the rest of the protocol. But I do like using that kind of dosing for an autoimmune problem like that.
Great. Thank you so much, Dr. Seeds, for leading our talk this evening. Again, and I appreciate everyone for taking time out of their evening to participate in the webinar. I would like to stress again to please visit the forum for anyone whose questions did not get answered this evening. And we do expect to have the webinar from tonight uploaded to the website within 24 hours. You will also be receiving a monograph over tonight's talk as well. And I think that's it. So we'll see everybody back in 2 weeks. Everyone have a good evening. Thank you.